Let's dig into some specific neurologic disorders. We're going to start with pain, and you might not think of pain as a neurologic disorder like you would seizures or strokes, but pain has a lot to do, has everything to do with our nervous system and how signals are sent from, let's say, our fingertip up to our brain, back down to our fingertip to experience pain. So how do we experience pain? How do we react to pain? Do we feel it at all? Are we hypersensitive to it? Do we have neuralgias going on? So this has everything to do with the nervous system. So let's take a moment or three to talk about pain. Now we can categorize pain a few different ways: somatic, visceral, and neuropathic. Somatic pain, think of dermal tissue pain. If you get slapped, right? If you get slapped, that's somatic pain. It hurts. Visceral pain, think abdominal pain, something coming for your viscera from inside. Right? I've got abdominal pain, maybe I've got appendicitis, that's visceral pain. And then our neuropathic pain comes from nerve damage and those neuropathies. Medication-wise, we have analgesics, a big fancy way of saying painkiller. We've got a couple flavors of painkillers in our toolbox. We've got our opioids, and we've got our non-opioids. Opioids are going to act in the spinal cord itself and on the transmission of pain, so that communication is broken up. The non-opioid painkillers is actually inhibiting the pain impulse right there at the stimulus in our peripheral tissues. So think ibuprofen for your non-opioids and maybe fentanyl, morphine for your opioid analgesics. Digging a little deeper into our opioid analgesics, we've got opioid receptors in our bodies. We've got a number of different ones, but three that we need to focus on. We've got mu receptors, kappa, and sigma receptors. The most pain relief we're going to get are from those mu receptors, and that's where our morphines, our fentanyls, our codeines, they hit the mu receptors primarily. They hit those pretty hard. So side effects there, we see that respiratory depression, we see that decreased GI motility, we get a little bit of euphoria. Our kappa receptors, you'll see more in spinal sedation, and then our sigma receptors, if we activate those, lots of hallucinations, lots of dysphoria, lots of euphoria. Our opioid medications that are available to us come in different, strengths. So our strong opioids, class 1 morphine, goes after mu receptors, also kappa receptors just a little bit, creating that pain relief, a little sedation, a little euphoria. Does come with nausea, vomiting, does come with lowered blood pressure because of some vasodilation. There is a histamine release with morphine. Longer term use or heavier use of morphine and really any opioid is going to decrease your GI motility and cause constipation as a side effect. Other strong opioids to mention, we've got fentanyl, which is a very potent opioid agonist, also available as transdermal patch, so you might see patients with that patch on their chest, on their upper arms. We've got fentanyl at our disposal. You also might see Demerol, methadone used in opioid addiction and treating that. Methadone really takes out the euphoria of the opiate, but still allows for binding to our opioid receptors and decreasing withdrawal symptoms. And then we got things like oxycodone, which is a combination opioid. And what do we mean by combination opioids? Well, we've got, say, oxycodone, and if we combine it with a little bit of Tylenol there, we get Percocet. So if you hear Percocets, if you hear Percodans, same thing, combination, and they're usually combined with an NSAID. So things like Percocets and medications like Vicodin are all these combination opioids, where they get opioid combined with an NSAID, non-opioid pain reliever. Now we're not going to be giving Percocet or Vicodin on our truck, so as paramedics, what can we give for pain control? We've got some NSAIDs, some non-opioid analgesics at our disposal. We've got ibuprofen, typically given at 10 mg per kg, usually in that 400 to 800 milligram range. It's just PO. Same with acetaminophen, Tylenol, 15 mg per kg, up to 1,000 milligrams. We've got ketorolac or Toradol. If you're giving it IV, it's going to be 15 milligrams. If you're giving it IM, it's going to be 30 milligrams. Toradol is fantastic for kidney stone pain and for back pain. It's typically the go-to first line for those two complaints. And then also don't forget aspirin. Aspirin is both an NSAID and it also is a pain reliever. So not just given for chest pain as an antiplatelet drug, but can be given for pain control. You can give that 324, that standard dose we think of for aspirin. For pain control, we can even go up to 650 milligrams PO. Moving a little further, we've got opiates, we've got some dissociative drugs. There are plenty of opiates out there to choose from. The main ones we want to highlight here. We've got morphine and fentanyl as our opiates. Morphine, typically we start at 4 milligrams IV, repeating every 5 minutes or so as needed. Just titrating up by 2 milligrams at a time, watching for those side effects. Same thing with fentanyl, 1 microgram per kilo, or somewhere in the range of 50 to 100 mics per dose for an adult, repeating again every 5 minutes or so, depending on the response, depending on side effects. On our dissociative side, we've got nitrous oxide. Usually comes in a 70-30 or 50-50 mix of the nitrous and oxygen. We do need to mix oxygen with it because the patient still needs oxygen, right? That is just an inhaled dissociative. The patient controls that, so if they've had a little bit too much, it's a handheld device that they're using to take in the nitrous. They have a little bit too much, well, their hand just kind of falls away. They take a few ambient breaths, that nitrous is released, and they come back to. So it's very quickly released from the body, and the patient comes back to baseline pretty quickly if they accidentally take too much, and then they can take their handheld device and start puffing again. Another dissociative is ketamine, used for pain control on the lower end of the dosage for pain control, usually starting around 0.3 milligrams per kg over about 10 minutes or so. We're not going to slam this in. We're going to be looking for side effects, adverse reactions. We're going to repeat that every 20 minutes, give or take. Most protocols call for a maximum of 3 doses, and then kind of calling it a day there. We don't want to give them too much ketamine and move into a dissociative state. We're staying in that pain control band for ketamine. Here's a sample pain control protocol for you. You see, pain, is it mild? Is it mild or moderate to severe? On the mild side, we're thinking that non-opiate NSAID side. We've got ibuprofen, we've got Tylenol, we've got aspirin. If not, we can move over to our opiates and our dissociatives, and nitrous oxide. We've got fentanyl, we've got morphine, we've got ketamine down here. There is nitrous oxide in there if it's available to you. So this is all based on local protocol and what your agency allows you to do. But nationally, these are the primary pain control mechanisms that are available to us. And from pain control, let's move over to vomiting, because when we give opiates especially, a common side effect is nausea. That nausea can turn into vomiting. So with a lot of these opiates, we'll give the opiate. We'll also give an antiemetic, just prophylactically, because that morphine can cause nausea. We want to get ahead of the game there. So we're going to stay ahead of the nausea and give antiemetics. There are lots of antiemetics out there for us to choose from, and there's a lot of ways we can trigger nausea, but we'll just focus on a couple here. In the pre-hospital world, you will most often see 2 antiemetics available for us to give. The big one is going to be Zofran. It is a 5-HT antagonist, primarily 5-HT, so it's blocking serotonin receptors. blocking communication with serotonin. So the Zofran, given 4 milligrams either IV. We can also give it via dissolving tablet, an orally dissolving tablet. That's usually our go-to, Zofran. If we need to hit them a little bit more heavily, we've got antidopaminergics, promethazine or Phenergan. It's a pretty heavy drug, comes with pretty heavy sedation, starting at 12.5 milligrams up to 25 milligrams IV. We can even cut that in half further for, let's say, elderly patients. If I've got an 89-year-old patient, I'm probably going to start them off cutting that 12.5 in half, again, giving them 6.75 milligrams, starting low. We can always titrate up. But Phenergan, lots of sedation comes along with this drug, but it is a potent antiemetic. And then with any discussion of opiates, we need to talk about opioid antagonists. So Narcan, naloxone, is going to be our primary opioid antagonist, trying to reverse any unresponsiveness, any respiratory depression. It is an antagonist of both mu and kappa opioid receptors. We start with 0.4 up to 2 milligrams. You can give it IV, you can give it IM, you can give it IN. Some IN doses go up to 4 milligrams per dose, so it just depends on what your, again, local protocol is, what you have available to you. But start low, titrate up as needed. So we want them to just have enough to be breathing adequately and maintaining their own airway. So the goal is not to completely wake them up, completely regain consciousness. If we give too much or too much too quickly, that also induces vomiting. So we want to give enough just to get them breathing again and protecting their own airway. Now, let's get into some specific neurologic conditions and some specific conditions by starting broad. Like coma, your patient is unresponsive, some deep state of unconsciousness, and there are just dozens of reasons why they might be unconscious. And this is where you're thinking back to your mnemonic, your AEIOU tips mnemonic comes in handy, and just going through that methodically and ruling in, ruling out any causes of this unresponsive state. Neurologically, could also be tumors or some space occupying lesions. Lots of different types of tumors, lots of different pathologies behind it, lots of different signs and symptoms of it. Anything from headache to seizures. Look for ataxia. Look for differences in behavior if the family tells you the patient has been acting just completely different. Their personality is completely changed over the past period of time, over the past days, weeks, months. Be thinking maybe some sort of tumor, and the manifestation of these signs, of these symptoms, is going to be dependent on where that lesion is, where that tumor is inside the brain. Next, let's talk about dementia and the different types of dementia. Dementia itself is a general term, it's a broad term, and encompasses a number of diagnoses. But dementia is just a progressive decline in mental ability, mental acuity, and resulting in brain disease, and is considered irreversible. We don't have a good cure for it. We have symptom management is what we have for the different types of dementia. Alzheimer's disease is one type of dementia. It's a progressive dementia. And in Alzheimer's, we've got cholinergic neurons that are being destroyed. And these neurons play a role in memory. The hallmark of Alzheimer's is this loss of memory, and it's because of the destruction of these cholinergic neurons. So there's neuronal destruction and damage, along with cortical breakdown in the brain. Neural is the word I was looking for. Neural breakdown. Treatment of Alzheimer's. Think of Aricept is the go-to treatment of Alzheimer's. Again, it's symptom management. It's meant to slow down the progression of Alzheimer's. It's a cholinesterase inhibitor. So remember, back to acetylcholinesterase, it's one of those inhibitors, so it allows for more acetylcholine and more neurotransmission between those neurons that are being damaged, so there's more neurotransmitter in there. Another disorder that falls under the broad dementia category is Huntington's disease. It's a hereditary disorder. Typically shows up and begins in the patient's 30s. It's progressive. It'll progress for the next 10, 15 years. So what we see in Huntington's is a lot of involvement with the limbs, the tongue, the face, involuntary movements, weaknesses, and eventually death due to respiratory depression and an inability to breathe. What's at the main cause of Huntington's is a degeneration of GABA neurons. So there's excessive dopamine activity, dopaminergic activity. So treatment-wise, again, just symptom management. What do we want to do? Well, we want drugs that stimulate those GABA neurons. The GABA neurons are damaged. We want as much activation as possible. So think benzodiazepines. That might be on something like Valium, diazepam. And that might also be on medications that block dopamine receptors. So we've got this excessive dopamine activity going on in the brain. We can give medications that block dopamine receptors, like Haldol, haloperidol, to try to control some of the symptoms of Huntington's. Moving on from types of dementia, let's talk a little bit about demyelination and issues of demyelination. And what we have is these myelin insulators around nerve fibers. And with demyelination, that myelin just gets eaten away. And when that insulation goes away, the transmission along those nerve fibers gets interrupted. So think about your electricity cables in your neighborhood. You want them wrapped, you want them insulated. That allows for good electricity to pass, good electrical function. And if that insulation is disrupted, electricity is allowed to go anywhere, right? So it kind of disperses. Same thing with our neurons. We want good insulation around our nerve fibers. And with demyelination, that insulation is torn away. And within demyelination, we've got multiple sclerosis, wherein the myelin is gradually being destroyed. So it's this progressive disease. It's thought to be autoimmune. That's the prevailing theory. And symptoms can vary depending on where that demyelination is occurring, but it will progress completely. And symptoms just ranging from numbness, tingling, and it will progress all the way into paralysis. And although MS is incurable, it is not typically fatal. Some will progress to paralysis, many won't. So we're treating with medications that control symptoms. Again, we're under symptom control here. And any kind of acute flare-ups, acute episodes or exacerbations of their MS. Guillain-Barré syndrome is another demyelination disorder in which patients are going to report weakness, they're going to report sensory changes, maybe numbness, maybe tingling, having difficulty walking, might be a little ataxic. Also difficulty swallowing. Treatment here, again, is symptom specific, depending on their exacerbations, on their flare-ups. So as they increase with intensity, they may progress towards paralysis. They may not. So treatment here out of hospital and with their primary care physicians and their neurologists is going to be symptom management. The third demyelination disorder we'll talk about is ALS, amyotrophic lateral sclerosis, or commonly called Lou Gehrig's disease, where we have that demyelination occurring on nerves that control our muscular activity, right? So patient's going to start complaining of weakness, specifically in the extremities, hands, arms, maybe down at the legs. This is a progressive demyelination, a progressive disease, so it will progress to inabilities to swallow, to move, will progress to paralysis. And usually the prognosis with an ALS diagnosis, once it is diagnosed, is about 5 years. Alright, now let's talk movement disorders. The first of which we'll talk about is a broad one. It's dystonia. So dystonia, just changes in muscle tone, usually muscle spasms and rigidity, fixed postures, strange kind of movement patterns. There are different types of dystonias we're not going to get into, but just dystonia as a broad term with this muscle rigidity. Next up is one you've probably heard of, muscular dystrophy, which is an inherited genetic disorder. So if a patient is diagnosed with muscular dystrophy, definitely parents, any siblings, any close relatives should be genetically tested for it. So it's this inherited genetic muscle disorder. We've got these degeneration of muscular fibers. So it is a progressive disease, muscle breakdown, and then leading to heart failures, pulmonary infections, leading to death. So there's no effective treatment. Again, treatment is symptom-based, so just symptom management for our muscular dystrophy patients. There are many forms and types of muscular dystrophy, so kind of falls into many categories, especially that limb girdle, or over 30 forms of it. So it just depends on the patient. Patient will, once diagnosed, they're typically very well educated on their form of muscular dystrophy, or the family or the caretakers are, and will be able to communicate that with you and what they need in terms of symptom management and care onto the hospital. The other movement disorder we'll talk about is Parkinson's disease. This is a degeneration, a destruction of dopaminergic neurons. So we've got decreased levels of dopamine and excessive cholinergic activity. So our cholinergic neurons just run away, excessive activity on our cholinergic side. There are plenty of signs and symptoms of Parkinson's, many of which we are already pretty familiar with. Looking for those tremors, a shuffling gait, differences, changes in their extremities and movement in their extremities, just the way the patient holds themselves up, right? And looking for those tremors, rigidities, the posture, all indicate Parkinson's. For Parkinson's treatment, again, it's symptom-based, but if the primary cause of Parkinson's symptoms is going to be destruction of those dopaminergic neurons, we want as much dopaminergic activity as possible, so we want to increase dopamine levels. Two popular prescription medications that do that are levodopa and carbidopa. Alright, now let's make a kind of a full circle here. We're going to come back to our cranial nerves and talk about some kind of specific cranial nerve disorders. Not all of them. We're not going to go through all 12, but we will point out and highlight just some cranial nerve disorders that you might run into as a paramedic. Probably the most common one you will encounter is Bell's palsy, caused by cranial nerve 7. Usually inflammation of cranial nerve 7, or some dysfunction of it. You're going to have this unilateral paralysis of the face. You'll see drooping of the face. Pay attention to those the eyebrows on one side. They won't be able to waggle their eyebrows on one side, and you'll see this droop. That'll be a sign of Bell's palsy. We're still doing a full stroke assessment on these patients, but Could be Bell's palsy, and your patient may have a history of it and be able to tell you that yes, this is it's a normal thing when my Bell's palsy kind of flares, is exacerbated. Then there's trigeminal neuralgia, which is usually infection or some sort of disease of the trigeminal nerve. That's cranial nerve 5. So your patient's going to have these sudden episodes of just pain, extreme pain, especially around one side of the face, but around the cheek, the lips, the gums, is where that nerve kind of innervates. And we have got issues with that nerve, that's where we're going to have this sudden onset of pain. So if you've got a patient, sudden onset of one-sided cheek pain, kind of mouth, lips, gum, chin pain, be thinking trigeminal neuralgia. And then a last one to just mention, it's somewhat rare, uncommon, but that glossopharyngeal nerve pain, when that gets irritated, cranial nerve 9, that gets irritated somehow, severe pain again, that neuralgia, but in the throat, especially the tongue, the tonsils, maybe up into the ear. If you have any questions, please let us know.